So welcome to Grand Rounds this morning. I hope you've all recovered from the Super Bowl. I still hope you recover. It's my pleasure to introduce our visiting professor, Dr. Dale Smith. Dr. Smith is a professor of military medicine history at the Department of Military and Emergency Medicine at the Uniformed Services University of Health Sciences in Bethesda. He received his PhD in history of medicine from the University of Minnesota. I was just talking to him that our department has its origins from the University of Minnesota. He moved to the Uniformed Services University in 1982, and he is a nationally and internationally renowned historian of medical history. His primary interests have been in the history of military medicine and surgery and infectious disease. He has received numerous teaching awards, was recognized as on multiple different levels from the Uniformed Services University. He's honored with the Uniformed Services University Medal for his commitment to academic life in the university. His professional interests include, in addition to infectious disease surgery, also patient evacuation and military operations. And he's going to speak today on war and the management of trauma, a historian's view. Dr. Smith, welcome.
We have been sending people to patch up the for about as long as we have records of people being damaged. This is Ambrose Paré, the great medieval early Renaissance surgeon, supposed to have rediscovered ligature. Lots of people rediscovered ligature in the 16th century. It came with learning about anatomy and figuring out the arteries and the veins were different, and you ought to tie off one. History is like that. It's stories. It's stories we tell each other, kind of like in the family. Your grandparents told you stories. Your parents told you stories. They were stories of the family. These are the stories of the profession. And we tell them for that same reason. When you were, well, the group varies, 17 to 13, you went out on your first date, depending on the decade in which this happened. And as you were leaving, your mother or your father told you, remember who you are. What are the values of the family? What do we expect you to do? And it harked back to all those stories you were told about character and family and development. And that's what we're going to do today. It's not a cookbook. Dr. Kissinger reminded us. You have to use your history to interpret the present. Now, I don't have any conflicts of interest in the traditional sense, but as Benjamin Franklin reminded everybody, history is not a science, and you get what I think is important. And in that sense, you need a word of warning. This is a historian's view. But what stories do we tell? What's their purpose? How do we shape the profession? At the end of the 19th century, the profession changed. Joseph Lister applied the antiseptic principle, and then people began to move on to the aseptic principle. And surgery was transformed by 1900. But in that transformation, there was a lot yet to learn. In 1914, in Sarajevo, things went to heck in a handbucket. And a set of treaties were called in that resulted in Europe becoming an armed camp. What we call the Great European War. Until a few years ago, if you went to the Library of Congress cataloging system, there was still a subject heading European War. There was a World War II subject heading, but there was no World War I subject heading. because we thought of it as the European War from 1914 through 1916. As more and more trickled over, we began our own readiness group, and surgeons became an important part of that. The military realized they didn't have enough resources, and they called on the Red Cross to help them develop hospitals and nurses. And a surgeon by the name of George Cryle, who was primarily an academic in Cleveland, went to France, along with Harvey Cushing from Boston, to staff an American hospital in Paris. They recognized that a lot was being done and they needed to help prepare America. They came home and talked to the Red Cross about setting up reserve hospitals. One of the things they noted was something that was being debated in the American literature, and that was the management of fracture. Nobody wanted responsibility for that. Even with antisepsis, the physiologic problems of the patient resulted in bad outcomes a lot of times. Healing was difficult, and there was a lot of confusion. As late as 1909, the American Surgical Association, now you have to grant that the American Surgical Association is not necessarily the midpoint in a man's career, but they voted that x-rays were not really required in the management of fracture. How do you do that? Well, they came up in a different era. And so this fracture business was getting difficult. On the war front, Sir Robert Jones, the consultant for orthopedics in the British military, pointed out that you had about a 95% fatality rate from what we would call a type 2 or a type 3 fracture. You needed to get people into traction, and he did. As this worked out, the fatality rate dropped to about 20%. The Thomas Splint was deployed, antiseptics were used, new methods of managing antiseptic on the wards with the Carroll Dakin solution were put in. The war kept breaking in on us in a civil way. The president didn't want us to go to war. In fact, he ran on a platform in 1916 that he kept us out of war. He was inaugurated for his second term in March of 1917, and in April he asked for a declaration of war. Politicians have not necessarily changed. Our immediate deployment was General Pershing and his staff. We had nobody to send. We were mobilizing an army. We had the round-out portions of the brigade in the divisions. We promised the people of America that their sons and daughters would get good care. The Red Cross would provide the nurses, the reserves would provide the military, and it was a phenomenal group of people. The leaders of American surgery, urology, and Dr. Young, Dr. Finney from Johns Hopkins. And for the purposes of understanding the orthopedic story, Joel Goldthwait from Boston. As Goldthwait became the ETO consultant, he looked at what was being done and he realized that, in fact, long-term management, not immediate management, was what was required to make the surgeon successful in managing traction, in managing fractures, in managing infection. The surgeons that went learned a new word for sorting called triage. The French influence on our profession is profound. They tried to take their antiseptic and aseptic principles to war, but the reality was the farms of France were germ-laden. Tetanus was a problem. Antitoxin was used. Major Cryle went, having worked on blood transfusion as a research problem, and he looked at the British. He found a young man named Joel Robinson. Robinson had been a student in New York where people had taken up Cryle's idea of vein to artery transfusion. Direct anastomosis was the only means available before this war. And he began to collect blood in paraffinated bottles and pump it into other people. Shortly thereafter, A different Robinson, an American Robinson, Oswald Robinson, coming out of a research tradition in Philadelphia and New York, found that his culture work allowed him to citrate blood, and you could keep it a little longer. And just at the end of the war, he was taking blood forward in citrated bottles. We saw other patients who also had shock, but they weren't wounded. A physiological change, what we would now call a neuropsychiatric casualty, was called shell shock. Understand that the same word, wound shock, hemodynamic shock, shell shock, was being used. People did not understand the physiology of wounding. The war ended. The military changed. They built new tools. For our purposes, medicine changed, particularly surgery. The American College of Surgeons set up a committee on fractures. And orthopedists began to become interested in fractures in ways they had not been. It had been a general surgery problem before the war. If you think about the orthopedics, it's about the small people and the congenital abnormalities that are corrected, other problems that develop in bone, but they weren't considering themselves traumatologists in any way. Now, with Goldthwaite's influence, as well as others, orthopedists began to look at the issues of fracture as a longer-term management issue, similar to what they do with abnormalities. General surgeons may handle it in the casualty phase, but they turn it over to orthopedics for its management. By the time of the war with Spain, the Spanish Civil Wars, we began to learn about management and long-term infection control, and Winnett Orr, just before the Second World War, published an important book that shaped orthopedic management in the Second World War. But still the problems of infection and healing. During this time, the sorting out of specialties began to occur. If you're a gynecologic surgeon, you ought to be able to do abdominal surgery. They're right next to each other. Is there enough head surgery to do? Do you really need people that do neurosurgery? Harvey Cushing's trainees from Harvard would often do something else. Claude Beck is probably the most famous at Cleveland. He makes fundamental contributions to neurosurgery and to cardiac surgery. He doesn't feel like he's inhibited in any way. But others wanted to specialize. They wanted referral patterns to develop. There is a growing sense that there's too much to manage, but people need a way to sort them out. And in the 1930s, at the height of the Depression, we began to create our modern board system. The ending of the First World War was not what everybody wanted, and particularly in Central Europe, people began to campaign. And in 1939, a new European war broke out. It didn't work well for the British and the French this time, evacuations at Dunkirk. And it appeared that the Nazis and the fascists were going to take over the world. London was being bombed. And the effort to help them led people like Charles Drew, who had been studying the collection of blood and the separation of blood, to work with the Red Cross to send blood to Britain. Became our problem in 1941 in December as we had an attack at Pearl Harbor by the Japanese, and we found ourselves involved in war. We were committed to Germany first, but Germany was now in North Africa, and so we launched an invasion of North Africa to support the British. We built our system on that emerging consultant system from World War I. Regular Army officers like General Kenner would be the senior surgeon, but there would be a consultant, in this case in North Africa, Edward Churchill, the professor from Harvard who became a colonel. He began to set up surgical units. And he realized that this new specialization was important, but there weren't enough specialists to do everything. And so he created a group called the Auxiliary Surgical Unit, essentially an operating team that could be deployed wherever you could hold patients. This is Brewer and his operating team that were doing thoracic surgery from Churchill's training. And they recognized that their casualties from thoracic wounds were drowning. And in Italy, they came up with wet drum lung syndrome and began to use positive pressure oxygen to relieve that problem. a gross organ-based physiology in the management of patients, they began to struggle with this physiologic management of the patient in trauma. The same problem that the orthopedist had observed in the previous war. At about the same time, there was a phenomenal fire in Boston, a very crowded nightclub called Coconut Grove. A lot of burns, other trauma from being trampled and such, but it was the burns that killed people. Francis Moore had been one of those faculty members who'd been left back in the country to keep the pipeline flowing. And as he looked at the management of those patients, he began to think about the physiology of the burn and the metabolic nature of the surgical patient. The first issue was blood, and they were pioneering blood. The British had not forgotten those lessons of World War I. They were collecting blood in the field. The field transfusion unit, you can see there, has a symbol of the vampire bat. This was awarded to them by their peers because they were bleeding the rear area troops to provide blood for the forward area troops. Nobody was sure that we could get blood forward. The Red Cross was collecting it, but it was generally turned into plasma. It would be 1944 before we corrected an error in a committee minutes. In 1940, we had determined that the shelf life of iced blood would allow us to get it anywhere in the world in a timely way. But by failing to capture the details in the committee minutes, it went forward through a bureaucratic process from research to application that said blood would not last to get to Europe. And it took 2 years to correct that clerical error. When they did, we got blood in time for D-Day, but not in time for North Africa, the Mediterranean, and the early battles in the Pacific. The planning for the invasion of Europe had exactly the same pattern as we see in North Africa. A regular, in this case Paul Hawley, and an academic, Elliot Cutler. They planned for their work. The beaches were bad. Evacuation was a problem. Shock was severe. Forward management and control, forward use of blood, evacuation, stabilization through an echeloned care system by this point was well understood. It continued in Europe. Corpsmen stabilize and tag the patient, move them back for the control of bleeding to some sort of forward surgical unit that would then move to a casualty receiving station where those auxiliary surgeons would do their work. Blood was brought forward as the airplanes were used to evacuate people, but most people came out by train. We had to rebuild the trains because the Army Air Force had removed the tracks. And we managed patients extraordinarily well. Died of wounds rates in Europe fell from about 6% at the beginning of the war to about 3% at the end of the war. Part of that was evacuation improved. Part of it was the isolation of patients. Sometimes things didn't work out like you planned. The winter of '44 was an example. We had another tool besides blood. By late '43, early '44, penicillin became online on a regular basis. We used it isolated in '42. The operations in the field. By the spring of '45, surgeons began to think they had, in fact, beaten most of the problems. The military was, in fact, beating the Germans. And in those auxiliary surgical groups, a new idea. We have had doctrine that will not let us do vascular repair because you need to hold the patient for a period of time. A young student of mine named Justin Barr, who's a surgical resident at Duke right now, looked at those records, and in the spring of '45, those two auxiliary surgical groups began to do vascular repairs. Why? Because they felt they could hold the patient long enough for the repair to take before they had to be forced to evacuate them by the military sitting. But data were not sufficient. The war ended. People came home like Isidore Ravden, who'd been with the 20th General Hospital and then a consultant, with a young Quaker surgeon, Jonathan Rhodes, they began to think about the nutrition of patients. Moore continued his work on the metabolic care of the surgical patient. But perhaps the most innovative unit was an Army unit that looked at the use of the antibiotics in burn patients, which in 1947, with the shuffling around of a variety of Army units, it was sent down to San Antonio and became the Army Burn Center. Burns have a nature of complex physiologic injury by their very nature. And so the study of the physiology of healing was probably done more systematically there than anywhere else in the 40s and 50s. Some of the civilians stayed on active duty to help set up military training programs because everybody was now going to be a specialist. Part of this was because the war convinced everybody that specialty care was the best care. If you were a physician, you had boards, you came into the military as a major. You stayed in a general hospital, or at least a rear area hospital. Many of them were air conditioned. You had a good place to sleep at night. Your meals were on a routine basis, sitting at a table. If you were not, you came in as a first lieutenant and a general medical officer. You were assigned in the battalions. You slept in the mud. You had a tent if you were lucky. And you got shot at. There is no definition of social worth quite as profound as distance from enemy bullets. So the people that came out of that war said, people think more of specialists than they do of generalists. I'm going to be a specialist, and you'll notice the graph there. Specialty has increased at an exponential rate. At the same time, if you were a soldier and you got sick or wounded, you were moved from that battalion aid station back to a general hospital where specialists took care of you. We had the phenomenal luxury that 40% of America's doctors were in uniform during the war. 8% of Americans were in uniform. If 40% of the doctors take care of 8% of the patients, you create a new expectation of care. So people felt they ought to have access to specialists, and the medical profession responded. New areas that were being pioneered at the time, things like arterial repair of gross pathology, led people like DeBakey to think about how you could do that more efficiently. His mother had been a seamstress. He used some of the new DuPont fabric to build his own materials. We found ourselves at war again. General MacArthur was not prepared for war. He sent a small unit, Task Force Smith, with World War II equipment, and they met Koreans with Russian equipment. We mobilized the reserves, and they began to hurry home. We fought on the ridges. We were pushed back to Pusan. Because we had air superiority, we didn't worry much about putting search and rescue forward, and the search and rescue people were underutilized, and so they began to evacuate patients from the battalion aid station back to the MASH, a new unit based on the Auxilary surgical unit with some holding capacity. Aeromedical evacuation, then back to Japan. And the Korean War managed trauma very well. By the end of the war, it was a stabilized line. We were using nurse anesthesia in the MASHs. We were doing sufficient care to stabilize the patient prior to movement. People at Walter Reed put together a surgical unit, and John Howard asked a young lieutenant colonel named Carl Hughes to go off. A Navy doctor who was not asked to do it did the same thing, and they began to do vascular repair. The surgery was being transformed. People were looking for new anesthetics. The physiological results of surgery were seen in Korea with renal failure, post-acute management, and so the new cough kidney was deployed, and patients recovered. The truce came. We knew about forward care in the MASH and evacuation. We knew first aid could do wonders, and we We were experiencing a new kind of trauma at home, death on the highways, cars that were not made for safety on new highways that were dangerous. We found ourselves in another war, a war that rapidly built up in Southeast Asia, again a helicopter war with helicopter evacuation. A long, skinny country, almost no place was more than 30 minutes from a hospital. But that forward care led people at home to think about turning first aid into something more. And so those evacuated patients who now were even more damaged had better results. Then they moved on to more definitive care. But as those helicopters showed up on the evening television, the National Safety Council asked the military to give them helicopters to work. And right here in Bexar County, the sheriff and the military worked together to tackle the death on the highways problem. Now, the reality is the data are very ambiguous. It's not at all clear that the initial helicopter efforts actually saved that many people, because the forward care that was given by a forward medic in the military was not necessarily yet available everywhere that you could land a helicopter. And if you don't do the forward care of role 1, the secondary care at role 2 is more difficult to manage. The transportation doesn't necessarily vary it. But it looked so good. It made such sense as social policy that we are doing something. And so today, you can't find a hospital that doesn't have a helipad. Better people recognized that that forward care was essential. The emergency medical technician, the forward care of surgical patients became an emergency medicine activity. And that burn unit had spawned a research unit, named the Institute of Surgical Research in the 1970. It began to move beyond the basic burn research to broader trauma research. And in civil life, the system of evacuating people led to really critical patients being semi-stabilized, put on helicopters, and brought to emergency rooms where they were immediately sent to surgery. And the surgeons found themselves dealing with patients that were almost like war patients. And they began to organize themselves into a community that believed that they were trauma surgeons. And in places like Ben Taub, Charity, Newark, surgeons began to recognize that they had a serious capability to do something for patients in a significant way. And they began to think about surgical research in trauma patients, taking up the work of the burn unit, more roads with parenteral nutrition, began to look at the phenomenal cascade that happens in trauma. In the 1970s, the 1980s, and the 1990s, the bits and pieces of a trauma cascade began to be worked out. By the time we came to war again, people began to think about that forward stabilization management. Frank Butler and a team of military doctors began to notice that combat casualty care had begun dependent on emergency medical technicians, and they needed a new kind of understanding that was based on a new understanding of war. In the 21st century wars, that tactical combat care set a new standard for stabilization, for rapid evacuation, and for forward surgery. Still, the strategic lift got you back to the hospital. But that pre-hospital trauma care moved rapidly again into civil life. So why am I telling you the story? Well, that which you already know, trauma care is challenging surgically. Skills can be lost War is still an epidemic of trauma. We learn. But I want a second message to come across as well. To change care, it must be provided in a context of research and education. Whether it's a burn unit, a recognition of blood forward, the problem of the physiology of the fracture. Each time we saw those empirical advances, they were doctors doing what doctors do, which is apply the basic science in a clinical setting, largely through analogy, the best they could. But slowly, in that Institute of Surgical Research, in those trauma hospitals where research traumatologists began to work on the physiology and metabolism of trauma, you began to see an institutional change, a prospective, careful definition of trauma management, because it had moved into a context, not of empirical emergency care, but into a context of research and education. That which you are about here is that which long-term changes the practice of medicine. It's necessary for going to war. War may give you a new set of problems, but there is a tie that means you have to carry your part as well. And so I invite you to think about what the empirical and epidemiologic data of this last epidemic of trauma that we've experienced say about our education and our research doctrines. Thank you very much.
Questions for Dr. Smith?
Like all sermons, it should change your behavior.
So first of all, that was a terrific talk. And I think your closing is beautiful and spot on. The other reason why I think the story is important, maybe a third reason, is that if you look at sort of our understanding of history and our facility with it, I think in the more modern times we're bombarded with information, but it lacks oftentimes context. And I think if we don't think about it, so you mentioned a 95% mortality from a grade 2 and grade 3 open fracture. The mortality at the time for a gunshot wound to the abdomen was about 90%. A 30% total body surface area burn had a 50% risk of death. That was the world prior to World War I. And so I think that's really important because if you deal with teams of young, middle-aged, and old people today, I don't think they realize the importance and actually of the significance of care that's provided. We watched the Super Bowl last night, and everyone's giving high fives all around, but nobody considers that the care of a femur fracture is a life-saving operation. That placing a chest tube is a life-saving procedure. Really, unless stitches are put in the aorta, people don't consider it too much of a big deal. And I think that's part of the problem with modern physician burnout, in that we don't really understand the impact and what's happened in the past 100 years. So I think this is a beautiful, beautiful talk.
It certainly is important for burnout. It's also important that the profession redeem its responsibility. The reason we set a profession aside is they have special knowledge. We expect it to be applied for the larger social benefit. When society gets used to life-saving operations, the next generation doesn't think of them as life-saving operations. Those football players don't think about the danger that they would have been in playing football 100 years ago. And so in some ways, people get immune to what's being done. And conveying how we change things from one generation to the next is a professional responsibility. You may notice I said a lot of those early practitioners improved things by their ability to empirically apply their science knowledge to their patient care. They didn't yet have a system of doing surgical research. That ability remains crucial. We can set up a standard of care that allows all kinds of people to take care of the 60% of the first standard deviation in any problem that fits the standard of care. You've got this signs and symptoms, you do this, they get well. But when that evidence-based standard of care gets frayed, the second and third standard deviation, then you don't get well. Then you need a physician, or in this case, a surgeon, somebody who can think about applying that science to the problem that doesn't fit the simple algorithm. And that you constantly have to remind people of, because you're the only ones that know. The people that make healthcare policy, whether in Chicago or Washington, don't really understand that. But you live it day to day. The residents here are learning how to do it. And that's what makes you a profession. And it's phenomenally important that you share that with the public. Dr. Pruitt.
An interesting review. You gave George Cryle a lot of credit for shock, and I've always thought he set it back a quarter of a century. He really came to his work, for which he got a prize, was that it activated the depressor nerve. Bizarre. And he gets credit for advancing the treatment of shock, only in a very negative sense.
Well, I think there are two ways that the story is told. The way I told it is blood transfusion helps with hemodynamic shock. That way, Cryle does have a crucial role. Why he thought he did it, a no-see association, as you say, was a fairly bizarre understanding of outdated physiology. And because people read about that, they did a lot of physiologic research that would have been better off if it never been done. But for the patient, having that blood in hemodynamic shock was many times the difference between life and death. The fact that the doctor didn't know why he was doing it is one of the things that needed to be corrected, and of course people like Alfred Blalock would 20 years later sort that out. And it moved you from about a 60% success rate in treating hemodynamic shock to about an 80% success rate in treating hemodynamic shock. Understanding is phenomenally important, but understanding is hard to get to because, well, one reason, great men make pronouncements that shape a generation of research that ultimately ought to be filed in the fiction section.
But it seems to me that Robertson had more to do with the actual use of transfused blood in World War I than George Cryle did, because he had blood that the British would ask him to prepare blood when they were going to have an action.
Yes.
It was delivered on site in World War I. I'm not sure Cryle was involved in that.
If Cryle had not been working from 1909 to 1916, Oswald Robertson would have never thought of giving blood. He was a researcher and not working on that problem. He was working on tissue banking. What Oswald Robertson brought to the problem, in my judgment, is the technique for preserving blood. Bruce Robertson, 6 months earlier, recognized the same thing from the same source, blood transfusion in the academic world. All he had was paraffinated tubes. Well, paraffinated tubes help, but it's a 5-minute move from the donor to the patient. Oswald Robertson gave us a month, and then after the war, they extended that. So, phenomenally important technical innovation, but I think it was Cryle's thinking about hemodynamic shock that came from his blood pressure measurements and following people that led him to do those blood transfusions in 1909, 1910, and got other academics thinking about it. I won't argue with you that, he messed up Cannon, he messed up Bayliss. The physiologists of the time were trying desperately to come to understand what he was talking about in a NOCI association. But at a pragmatic level, surgeons began to use transfusion in that, what we would call academic hospitals in those years before the war. And those young men, just like the young men in Korea who went out to do vascular repair, they'd seen it. And it ought to be applied here in this tent. And because they were young and foolish and full of vigor and vitality, they did it. And it worked. We need brave surgeons who'll try that their seniors say can't be done. We also need people to think carefully about doing that and balancing it. Balancing it's a phenomenally difficult thing. It's one reason that since the turn of the century, the surgical training program changed. Coming out of World War I, Dr. Finney, who was that year, 1920, president of the American College of Surgeons, noted for the first time over 25% of graduates were going to take a surgical internship before going out to practice. Then with the board, we had to have 3 years. And then in the 1960s, 5 years. And now if you want subspecialty or fellowship, I don't know, some of you will be here till you're 45. There's a lot to learn. And acquiring judgment on when to be brave and when to be careful, and when you can leave the standard of care and when you can't, turns out to not be taught carefully in a year. Sometimes that's been good. Someday I'll come back and give you a talk on the surgical disasters where young people were young and foolish, and it didn't help.
Questions?
Talking about vascular anastomosis, we have a surgeon laureate, not too many surgeons on Nobel Prize. Alexei Carrel is one of them. He's the first one to do the vascular anastomosis.
Yes, Carrel's triangular technique made it possible.
And not in France, here.
No, Rockefeller.
They didn't recognize him until he came and moved to New York. Now, you mentioned Dr. Kyle. Dr. Kyle, he was instrumental in cancer, in breast cancer. And he was the first one in America to promote not a radical mutilated mastectomy. As a matter of fact, his wife had breast cancer. He insisted that the surgeon does a simple mastectomy